on her Tuesday tea time. And it is my very proud privilege to introduce our own past VP, Dr. Kawita Bapat, madam. She is a very humble, ever smiling, cheerful leader of Foxy. But behind this ever cheerful face, there is a very, very, very serious think tank which always strives for the best of women health issues and best of the society. And our dear Dr. Kawita Bapat is the president candidate this year, and her motto is every member matters, north, south, east, west, but our member is first. So there is a huge, big CV of Bapat madam, and everyone follows her. And especially in our central India, she is our leader, and we try to follow even a small tip she gives. And she is past Vice President Foxy 2021 to 22, and she's director of Bapat Hospital Indore, and she is organizing secretary of AICOG 2022 in Indore, and she is the Monday hysterectomy queen, we can say, and she is the ICOG vaginal surgery certificate course center she's having, and she is Jogi peer reviewer, and she is in the World Book of Records for the contributor in the medical services. We welcome you, madam, for today's topic of
Thank
perineal care.
thank
And
you so much.
this topic, actually, madam is taking all those topics we all the gynecologists and obstetricians look forward for the pearls of wisdom, because we encountered every day these things, but we are clueless sometimes what to do. And today's topic is the perineal tear, and it is a very extremely common and expected complication of the vaginal birth. And laceration can occur spontaneously or iatrogenically, but sometimes we are really grade 1, grade 2, grade 3, grade 4, what to do, what not to do, how to answer to the patients and their relative, how to do the treatment, and what are the post-treatment complications, and what can be occur after first delivery, second delivery, third delivery. So um,
Thank
let
you.
us see the severe perineal laceration by Dr. Kawita Bapat, madam.
Thank
We
you.
welcome you, madam.
Thank you so much, my little sis, Dr. Jyoti Banglowala. Thank you so much. Today's topic is severe perineal laceration, and we have started this program of a tea time, half an hour program of learn simply with Dr. Kawita Bapat. The most important point is that the tea is the thing I'm telling you. The whole world is drinking, but the tons of tea at 4 p.m. India is drinking. So it's not a fun thing, and everybody loves to drink tea, maybe in from the north, south, east, and west. So tea time with us. And the most important, we don't want to spend much time in other things, but simple topic, which is very, very useful day to day, and what we do in our clinics and what is the take-home message. There are two cases I am going to talk, and these cases are very simple one, and which we have seen all of us who are practicing OBGYN know about this topic. 20 years old, post-dated pregnancy, 39 plus 4 weeks, gestation according to first USG scan. Admitted at a maternity ward with a planned induction of labor. So this is the thing. On examination, general condition fair, no pallor, icterus, dehydration or edema. Vitals, pulse 88 beats per minute, BP 110/70, temperature 98°F, respiratory rate 22 beats per minute. Per abdomen examination, uterus term size, cephalic presentation with no uterine contractions. Fetal heart sound 144 beats per minute. Per vaginal os, tip of the finger, cervix soft, uneffaced posterior. Head station 20, Bishop score -3, induced with 2 tablets of misoprostol. Kept in a posterior fornix after the vaginal examination, Bishop scoring at 4 a.m. and 10 a.m. She delivered a live male baby with 3rd degree perineal tear and cervical tear on the lateral wall. Total duration of the labor 4 hours, 23 minutes. Total blood loss around 100 ml. Placenta normal 500 grams. Baby weight 2,900 grams. Apgar score 7 by 10 and 8 by 10 at 1 and 5 minutes. No external abnormalities seen. Perineal tear repair done. Written consent was taken. Anesthesia saddle block. Intraoperative findings, 3rd degree perineal tear type C with rectal mucosa intact. Cervical tear on the left lateral wall, more than 3 centimeter. Retains small placental tissues and membranes. Uterus well contracted, 24 weeks. Procedure during repair, anal mucosa repaired, left side of the external and internal sphincter identified, held with Alice, where the right side of the sphincter was slightly difficult to identify, and both of them sutured with a figure of 8. Exploration, small placental tissues and membrane removed, left side of the cervix suture with a catgut, 20 interrupted sutures. Episiotomy wound was repaired. Postoperative management kept for 2 days in hospital. After 2 days, diet was changed to liquid, slowly to the semi-solid diet, non-bulk forming diet. Antibiotics, cefotaxime, cefixime, and metronidazole was given intravenously for 2 days and continued orally for 5 more days. Pericare and Perilite was provided, and this is the case 2. This is the case 1. I think everybody, this is not a simple something unusual type of case we are talking about. Simple patient, just induction done, and in a 4 hours patient delivered. So you can see the what can happen. This is the second case, 37 weeks, 38-week gestation. Came with a labor pains early in the morning with a history of leaking since 2 hours. Came to our hospital with good contractions. Examination, general condition stable, stable vitals. For abdominal examination, good uterine contractions. 3 to 4 last for 45/7, CTG reactive. PV 5 centimeter dilatation with leaking present. 70 to 80% effaced. Occipito anterior presentation, delivered healthy, 3.8 kg baby. Episiotomy taken at the time of crowning. The placenta was delivered by controlled contraction. After complete exploration, noticed a perineal tear. A tear extended from the introitus in the midline and torn muscle fibers suggestive of torn ends of the external anal sphincter. What is the diagnosis? What are the factors predisposes to this type of conditions, and how would you manage the patient? So these are the questions which arise. Everything was good. Everything was under control. Just a delivery, and why such a big perineal tear? So before that, I'll just put in a simple way. This is the classification of perineal tears. Degree of the vein and definition. First degree perineal tear, injury to the perineal skin as vaginal epithelium also. So make it a point. Second degree perineal tear, it involves the injury into the fascia and the muscles of perineum, which includes the deep and superficial transverse perineal muscles and the fibers of pudococcygeus and bulbocavernous muscle. Second degree lacerations do not extend to the anal sphincter muscle. So another important point. Third degree, it involves through the muscles and fascia, and perineum involves the anal sphincter complex, but it has got classified into 3 categories. If less than 50% external anal sphincter, this is a 3A. More than 50% external anal sphincter thickness torn, B3B, and 3C, both external and internal sphincter are torn. This is a 3rd degree perineal tear. And 4th degree perineal tear involves the perineal fascia, muscles, external and internal both sphincters, and anal epithelium also. So it's a most worrisome is the 4th one. So the severe perineal insertions, again, lower genital tract lacerations may involve cervix and vaginal perineum also. Perineal tears may follow any vaginal degree and are classified by depth, which we have already talked about. And then again, this is a repetition, but for the youngsters and the newcomers, they should know about it. The 1st degree tear, superficial laceration of the vaginal mucosa, extend into the skin at the introitus. It does not involve deeper tissues and may not require repair. So make it a point very, very important. Then the 2nd degree involves the vaginal mucosa and a perineal body, extend to the transverse perineal muscles, usually require a suture repair. Then the 3rd degree tear extends into the muscles of perineum, may involve both transverse and perineal muscles as well as the anal sphincter, but does not involve the rectal mucosa. So it's a differentiation between the 3. And the severe 4th one is anal sphincter and a rectal mucosa. Both are involved and are very dangerous. So the 3rd and 4th degree lacerations are considered as a severe perineal lacerations. May occur with or without an episiotomy. Midline episiotomies are associated with a greater risk of extension of a third and fourth degree tear as compared to the mediolateral episiotomy. Bleeding, despite a firmly contracted uterus, should prompt a thorough inspection of the upper vagina, cervix to exclude the genital tract laceration. Superficial cervical laceration up to 1 to 2 centimeters are not uncommon and do not require any repair unless they are bleeding. Deep cervical tears usually require surgical repairs. Extensive vaginal and cervical tears should prompt a careful search for the evidence of bleeding into the retroperitoneum, and it can reach up to the peritoneum. It goes through fornix, can go up to the fornix and can be into the peritoneum also. The frequency of the third and fourth perineal lacerations is 5 to 6% in a nulliparous and 0.5% in multipara. What are the risk factors? Why it happens and to whom it can happen? We should consider about it. Nulliparity, 7-fold risk. Increasing birth weight. The more, the bigger the size of the baby, chances are more. Again, the gestational. What is the gestational age? If it's post-term, close to the term, the chances of laceration are more. Then, if any operative vaginal delivery being done during that time is also important. If the position is occipital posterior position and then the rotation happens and then the baby comes out, that can happen. And episiotomy, 2 to 5-fold increase in nulliparous women and 4 to 5-fold multiparous women, there are chances of having a severe perineal laceration. And most important is a prolonged second stage of labor. Sometimes the perineal lacerations may be due to the precipitate labor, but sometimes, most of the time, it is because of the prolonged second stage of labor. Cervical lacerations occur in 1% in the nulliparous, 0.5% of the multipara, and its the factors includes young maternal age, operative vaginal delivery, if any procedures has been done, if a previous cerclage being done, these are the reasons. Now, how to repair? The surgical repairs to be performed in layers, beginning into the running the closure of the anal mucosa. The standard suture material is a chromic catgut, but synthetic material can be used, such as 30 Vicryl sutures can be used. The needle should be very small, tapered for the mucosa, SH1 needle, and the first suture should be placed approximately 1 centimeter above the apex and extend through submucosa. The mucosa is then closed and running or locking fashion and should not penetrate the mucosal layer. So it's a very simple, we should go through that and rather bring the submucosa together and the level of anal sphincter and the perineal body. The anal sphincter should be identified, and this may require Alice to retrieve the cuttages, incorporating both the muscles into capsule and which have retracted laterally. The important to suture of the fascial sheath, not just the muscles, when the repairing of the anal sphincter, since it's the sheath that gives the strength to the repair. So consider using 2-0 sutures for the capsule repair because it will give support for the longer time. 2 methods have been described to repair a laceration of the anal sphincters. First is end-to-end and second is overlapping. Most important. Both appear to have a small similar long-term outcomes are there. There is no proven benefit from perioperative antibiotics administration at the time of repair. And if antibiotics are given, single IV dose of a second-generation cephalosporin or clindamycin in a penicillin allergic patients is recommended. There are short-term complications. Sometimes there is a greater blood loss. Then there can be a puerperal pain and there can be infection and a wound disruption. If the pain is severe or persistent, physical examination should be performed to evaluate for the presence of hematoma or infection. Up to 1 in 5 women who sustain the obstetric anal sphincter injury will develop a wound breakdown or infection. It's another important point. Prior anal sphincter this laceration does not appear to be significant risk factor for the recurrence of laceration. So make it a point if it has been properly stitched and doing. So recurrence of the laceration chances are less. And most patients will go on deliver vaginally with subsequent deliveries. So nothing to bother about it. Should a wound infection to be identified, it should be treated with a severe perineal hygiene, oral antibiotics for 7 days. That's another important point. Sometime metronidazole should be included into it. Women with a wound breakdown to be offered immediate operative repair or conservative management with a wound packing and a perineal care. The wound can be surgically repaired when its surface is free and exudate and covered by healthy granulation tissue. So in rare cases, it can happen that a repaired episiotomies may lead to rectovaginal fistula formation. It used to happen when we used to be the students. This is where we have seen this type of things. But long-term complication of 3rd and 4th degree tears include higher rates of incontinence and dyspareunia. That's more important than formation of the rectovaginal fistula. So lower genital tract infection can be classified according to the depth of infection, and superperineal infections limited to the skin and subcutaneous tissue or the superficial fascia along with the episiotomy incision without necrosis. Again, important point is we are worried about the intermediate infection includes superficial fascia necrosis. We call it necrotizing fasciitis, and it is diagnosed when the following criteria are present. Number 1, extensive necrosis of widespread undermining surrounding tissue. Number 2, moderate to severe systemic reaction with altered mental status. So you can understand a simple perineal laceration can lead to necrotizing fasciitis, and it can affect even to the mental status. And absence of muscle involvement is another point. And failure to demonstrate the clostridia in a wound and a blood culture. Absence of major vascular occlusion. The patient can come with a gangrene or anything like that if she is having the necrotizing fasciitis in future. Pathologic examination of debrided tissue showing intense leukocytic infiltration, focal necrosis of fascia, and surrounding tissues and thrombosis of the microvasculature. Necrotizing fasciitis, as again we have talked about, severe superficial infection. Both layers of superficial and perineal fascia become necrotic as the infection spreads along the facial plane. It has acute onset, rapid course of the prominent systemic manifestation, and high fatality rate. Patient can die because of severe perineal lacerations. So deep infection in a myonecrosis, with this infection beneath the deep fascia involving the muscles and most commonly caused by the clostridia. Then sometimes we can see the acute perineal episiotomy infection in a severe perineal lacerations. It is acutely infected episiotomy should not be repaired. So make it a point very, very clear. Surgical exploration should be performed if the skin edema, erythema beyond the immediate area of the episiotomy. Sometimes the prolonged labor, so much pushing, so much so much trial of labor can lead that infection into episiotomy in acute one, and this is very troublesome. If severe systemic manifestation are present, if the infection does not resolve, after 24 to 48 hours, IV antibiotic therapy can be given. So just to clear it out, what we always talk about the algorithms, which I love to talk about and tell about. Suspected severe perineal laceration identified after vaginal delivery. Inspect the perineum, identify the degree of vaginal laceration. Inspect the cervix and the vagina. Be aware of all the risk factors. Diagnosis not confirmed, repair laceration as appropriate. If diagnosis is confirmed, repair laceration as appropriate. We can divide into two parts, immediate postpartum management or the delayed postpartum management. If we have to consider antibiotics, consider the stool softener, stool bulking agent for 7 to 14 days post-op, provide adequate pain relief and the perineal block, and observe for the complications. Delayed postpartum management, counsel the implication for the future pregnancy, schedule outpatient follow-up within 1 week of delivery, consider outpatient urogynecological consultation, evaluate for the treat of the wound complications. It's very, very important in the future medico-legal problem. If there is a superficial infection, antibiotic coverage, exploration, debridement, drainage of hematomas. If it is intermediate infection, empiric broad spectrum antibiotic, support the cardiovascular and respiratory system, surgical exploration and debridement. Deep infection, antibiotic coverage, wide surgical debridement, considered hyperbaric oxygen. Early repair of the episiotomy dehiscence, preoperative, clean the wound, remain the sutures, previous repair, scrub and irrigate the wound 2 to 3 times daily, sitz bath or the bowel movements, perioperative, IV spectrum antibiotic, reapproximate the tissue. Post-operative, sit baths 3 times daily, keep perineum dry, modified diet, avoid bowel movements, and repair included the rectal mucosa. Give stool softener or the stool bulking agents and monitor inpatient until the resumption of normal bowel function and the rectal mucosa. Thank you so much for the patient listening and for being with me today. Next Tuesday again.